Dr. Nabil, hi. Can I take your opinion about one patient of mine next door?
Sure, go ahead.
Well, I would like to take your opinion about Mrs. Halima, who is a 62-year-old female. She underwent a total mastectomy plus axillary lymph node dissection for 3 centimeter IDC.
Okay.
There were about 8 out of 15 lymph nodes positive, and actually she completed the chemotherapy, AC Taxol adjuvantly, and she came now for review. Would you recommend any further treatment?
Oh, sure. Well, what's her hormonal status then?
Oh dear, how could I forget that? Well, actually, she is ER positive, PR negative, and HER2 negative.
All right.
Axillary lymph nodes involvement post-mastectomy is an indication of radiotherapy to Case4, infraclavicular and supraclavicular lymph node areas. This treatment has been shown to reduce the local recurrence and improve survival. In a meta-analysis that included over 8,000 breast cancer patients from 22 trials, out of them more than 3,000 women had axillary dissection and positive lymph nodes involvement for whom radiotherapy was given. And this has shown to reduce the 10-year risk of recurrence of any type by more than 10% and the 20-year risk of death from breast cancer by more than 8%. Currently, the NCCN Panel recommends radiotherapy for infraclavicular, supraclavicular areas, internal mammary nodes, and any part of the axillary bed that may be suspicious. Can I ask you about Mrs. Afaf, who's with me next door with her husband, please?
Sure, go ahead.
Thank you. Well, so briefly, this is a 40 years old, very fit and well lady who underwent a breast conserving surgery and sentinel lymph node biopsy about 3 weeks ago. The final histology showed a 4 centimeter cancer. 2 sentinel lymph node biopsies were taken. None of them had cancers. She's ER positive and HER2 positive. So she has stage 2A breast cancer. Okay. So she came with her husband today to talk about adjuvant treatments, but she was asking whether we should do any tests before we start the treatments at all.
Well, what do you think?
The risk of developing metastases from early breast cancer is low. There is no data that demonstrates the benefit of CT scan, PET scan, or bone scans in asymptomatic patients with DCIS or early stages breast cancer. Additionally, overuse of systemic imaging may pick up false positive findings that could result in a delay in definitive therapy, along with leading to unneeded anxiety. In the NCCN guidelines for stages 1, 2, and operable stage 3A, that's T3N1 disease, bone scan is indicated if localized bone pain or elevated alkaline phosphatase. Abdominal or pelvic CT or MRI is indicated if elevated alkaline phosphatase, abnormal LFTs, abdominal symptoms, or abnormal physical examination of the abdominal pelvis. Chest CT scan is indicated if pulmonary symptoms are present. However, FDG PET scan is not usually indicated.
You had a 34-year-old attended your clinic to discuss possible adjuvant treatment post-mastectomy and SLMB for a 1.5 centimeter IDC, ER PR positive, HER2 negative, and 0 out of 3 lymph node negative. She had Oncotype DX test and the recurrence score is 4. What I would like to know from you is 1. What is the current stage? 2. What is the risk of recurrence? And 3. What would you advise for the adjuvant treatment?
Well, this is T1N0, this is stage 1. The Oncotype DX score is low for recurrence, so I don't think there'll be any benefit from chemotherapy. I think in her case, I will give her adjuvant tamoxifen.
Okay. So she has told you that she has multiple family members diagnosed with breast cancer and with endometrial cancer. Can you tell me which syndrome is likely to exist in this patient family?
Both Gordon and Lynch syndromes can predispose the individual to develop endometrial cancer. Gordon syndrome is an autosomal dominant syndrome characterized by multiple hematomas, skin lesions, abnormal CNS lesions, and an increased risk of developing carcinomas in the breast, endometrium, thyroid, and genitourinary tract. It occurs due to a mutation in the PTEN gene. Approximately 2 to 6% of all endometrial carcinomas can be attributed to germline mutation in the DNA mismatch repair genes. And up to 50% of female patients with Lynch syndrome will present with endometrial carcinomas as their sentinel tumor. On the other hand, while ovarian cancer is seen in 10 to 20% of female patients with BRCA2 mutation, endometrial cancer is not a typical malignancy associated with this mutation.
Dr. Hassan, a 40-year-old female on a routine mammogram was found to have a 3 centimeter right breast mass with no clinically evidence of axillary lymphadenopathy. What would you do next?
Well, in the first instance, I would take a full history and I will send her for a biopsy.
Excellent. Well, the patient told you that she has a history of cancer in her family, and the biopsy confirmed triple negative breast cancer. Now, would you please look at the pedigree diagram on the table and tell me which one do you think is representative of the patient family and why?
Hereditary breast cancer syndromes are autosomal dominant disorders. BRCA1 and BRCA2 are tumor suppressor genes whose role is to control cell growth and cell death. Mutations in these genes disable their functions, leading to increased cancer risk. There are several differences between the BRCA1 and BRCA2 related tumors. BRCA1 breast cancers are mostly triple negative, while the BRCA2 are mostly ER positive. BRCA1 gene is located on chromosome 17 with 50 to 85% risk of female breast cancers and 40% risk of ovarian cancer. BRCA2, on the other hand, is located on chromosome 13 with 40 to 60% risk of female breast cancer, 6% of male breast cancer, and 10 to 15% risk of ovarian cancers. In addition to that, BRCA2 gene also increases risk of stomach, melanoma, prostate, and pancreatic cancers.
We hope you liked our video. This is Acting for Clinical Education.
And don't forget to check the reference down below.
Please like, share, and subscribe. And don't forget to join us every Thursday, 5 p.m. Greenwich time.